Oh, that's even a. Is that
All right, I don't know who's on my committee. Me, John Brown, who's sitting there, Lori, and
You just remembered it?
Kusick. Tom's here. All right, that's okay. There we go. There we go.
The washrooms, the laundry rooms. I'm so happy.
No more talk.
Well, because I drive by it all the time, so it's kind of an eyesore to me.
Well, now we're going to shift gears. Okay. I'm going to call the Human Services Committee meeting to order. First, we have courtesy of the floor. Is there anyone who would like to address council? The Lamont McClure resident.
Thank you. 669 Washington Street, usually. So tonight, again, in the Human Services meeting, the theme was action. We're taking action to improve folks' lives. And in that context, it was with American Rescue Plan money. And I think that the potential for our collaboration with Habitat for Humanity to provide workforce or affordable housing is potentially game-changing for Northampton County. So there's a plan. When you couple that with what the GPA is doing with its small project with respect to affordable housing and some other exciting ideas we have going forward in the future about affordable housing, we are attacking that problem. But there are other problems. There is the scourge of opioid addiction and all of the concomitant problems that have occurred because of opioid addiction. And due to the ability of Northampton County to be an early adoptive litigator against the opioid manufacturers, we, of course, are going to receive large settlement dollars. And one of the things we're going to do, and you're just about to hear about that tonight, is put our focus where our focus really belongs, on our children who are affected by opioids, drugs, and alcohol, and our veterans. Those are going to be two of our significant groups of folks who have been affected by the opioid epidemic that Northampton County is going to use its funds to fight. Thank you.
Thank you.
Close the door.
It's courtesy of the floor.
No, could you close the door?
Oh, thank you. Okay, did you have?
No, I'm good.
All right, okay. First, we're going to have a report from the Drug and Alcohol Division.
So tonight I have Kathy Jurley with us. Some of you may know her formerly as Kathy Diltz. She is our current drug and alcohol administrator. So tonight you are going to hear from Kathy regarding the opioid settlement plan that we have been talking about, it feels like, for a long time now. And Kathy's going to go over briefly with you the allowable uses for that money, and then a laundry list of ideas that have been compiled with our providers and our internal staff for you. So I'm going to let Kathy do that, and I'm going to pass out the form that she's going to go over.
Good evening. Okay. So as Sue said, we do have a laundry list of items which she's passing out, and I will do my best to give you as many details as I can regarding the different strategies that we've come up with. But the main thing that I want to relay to you is that we were given, not only were we given this amount of money, roughly $11 million over the course of 18 years, we were also given an Exhibit E from the settlement. And what is on that Exhibit E is core strategies and other approved uses where we can use this money. So I'll go over those briefly, and then I'll touch on some ideas we've came up with. And all of the ideas that we've come up with, we have made sure that they have hit all of these core strategies, or they fall into one of these categories of the core strategies. We're not asking for anything that is questionable or might be construed as not an appropriate use of these funds. So some of the core strategies are expanding and supporting naloxone and MAT, treatment screening for pregnant and postpartum women, warm handoff and recovery services, treatment for incarcerated populations, syringe service programs, data collection and research, and prevention and educational programming. Some other approved uses are wraparound services, enhancing connections to care, drug courts, diversion programs, and criminal justice involved persons treatment, harm reduction strategies, supporting first responders, training, planning and coordination, treatment of opiate use disorder, support for persons in treatment and recovery, and misuse prevention. So those are the allowable strategies. If it doesn't fall into one of those categories, if and when we request money to do something with it, they will tell us no, because it doesn't fit into one of those categories. So I assure you that everything I will talk about this evening does fit into one of those categories. So one of the new ideas that we had was a mobile outreach van. We are modeling this after something that was created in New Jersey and has been proven to be very successful over there. Many of the counties in New Jersey do have this same model. They've copied it in Atlantic County, Morris County, Warren County, and several other counties in New Jersey. What it is a mobile outreach van that identifies entirely new groups and areas that were previously underserved and brings the services right to those communities. It operates with multiple partners to combat addiction. We have certified recovery specialists who can triage those who are in crisis and link them with appropriate services and treatment. They are in communication with treatment facilities to ensure that there is always bed availability, and this helps by eliminating stigma associated with help. A lot of times people don't reach out for help because of the stigma that it carries with it. So this is literally bringing the services to you so that you don't have to reach out for the services. Some of the services included in this mobile outreach would be drug and alcohol, mental health, veteran services, other linkages to services regarding case management, certified recovery specialists. We can offer Narcan training and distribution. We can partner with the Department of Public Welfare, in addition to street medicine to provide basic health needs and overall care. There would be a website, there would be a schedule, and we would have persons manning this van and taking it to various different locations within the county. Second item on our list is substance abuse prevention for youth. I have noted on there that we have already been in contact with Caron Foundation, and they do already provide some of these services in Berks County. So I did reach out. They're providing them in the Reading area. They offer a peak performance program, which is targeted towards high school and college athletes, educating them on the use of prescription drugs, opioids, and other substances for performance enhancement, and explaining the dangers of those substances and how folks in the sports world can get addicted to substances. That would be focused on a number of the athletic teams in Northampton County, both high school and college. Another program we are looking to institute is the Student Screening, Brief Intervention, and Referral to Treatment, or SBIRT. We are going to pilot that with a few ninth grade, high schools, and we're focusing them on the ninth grade population. So what we're hoping for is that by partnering with our SAP teams that are already in our schools, we can identify those in need of treatment, mental health, drug and alcohol, or other services, and we can directly, from the beginning of the school year, we can get those students linked to appropriate services, as opposed to waiting until there is an issue or a discipline referral to get them involved in SAP and getting them to the proper treatment. Some of the other uses we are looking at is our recovery centers. Currently, the county has 5 different recovery centers. We would like to get AEDs at all of the sites. We would like to work to make all of the sites ADA accessible. With that, we have already identified that 1 or 2 sites, based on their current location, is absolutely not feasible that they are going to be ADA compliant. So we would need to look at relocating some of those centers in the same area that they're already located in, to just make it ADA accessible so more of our population in the county can access services at those recovery centers. We've also looked at security and safety of our staff that are in those centers. And then other things such as storage, other essentials such as additional furniture, signage, and we've also talked about expanding one of our recovery centers' footprint by extending a food pantry at one of those centers. We are also looking at veteran services. We have identified that veteran services is a need in this county, and we are looking to partner with providers that are starting to implement vet services in inpatient and continue those through outpatient so that we can have a better link with veterans getting all of the services that they need. We want to find people in this area that are certified as specialists in this field, so that we can ensure that everybody's getting linked to the appropriate services. Moving down the list, adolescent recovery services. While we are not in a place right now to start an adolescent recovery center, we have identified that adolescents are in need. And we're working with Reach Lehigh Valley, who does have a recovery center up in Lehigh County, to partner with them to bring some of the services that they offer in that county to this county. We do have a location at the Palmer Recovery Center, which is separate from our general adult population, where they can offer some support groups and other interventions. So we're working on developing that program, and that's more of a future use if we can get things up and running there. Recovery events over the next 10 years, that is community events, resources, picnics, street fairs, those kinds of activities. Certified recovery specialist embedded in CYF for birth parents. So a big need that has been brought to our attention and has been identified, just based on my previous experience in children and youth, is that probably 80% of the referrals that come in for general protective services are somewhat related to drug or alcohol abuse. Someone in the family, a parent, a caregiver, is under the influence or has substance use issues. If we can embed a certified recovery specialist to partner with the folks at CYF, we can identify those people at intake and get them the link to the appropriate services that they need. Hopefully this will result in less kids coming into care, less foster placements, and more folks getting the services that they need. We would also like to expand school-based drug and alcohol services, and that goes hand in hand with the Karen Foundation and identifying those folks that need services. We're working with our Health Choices Division and our Mental Health Division to get additional school-based services, mental health and drug and alcohol into our schools. On the back of the form, you will see that on the top of the list there is certified recovery specialists for college counseling offices. So we are hopeful that if we can get some certified recovery specialists on college campuses, this will educate those folks on the dangers of binge drinking, alcohol awareness, prevention, and it will curb some of those, newsworthy articles where you see about frat parties and children overdosing because, college campuses are not equipped to deal with the substance use issues that of their students. Intervention services, we're working with providers to identify more providers that can provide additional intervention services because nothing formal exists right now. So we do have our case managers, which do link folks to appropriate services, but there's not one provider that offers just strictly intervention services. Founder's Day event, that is what I've been told is like a huge, large AA meeting. Folks generally charter buses, go out to Ohio, and those who initiated AA, created AA, it is a huge stadium full of folks where it is a huge recovery event. And when we sat down with our providers and some other folks, they've identified that that is really a moving experience and life-changing experience. And if more of our folks had the opportunity to do something like that, that would really be beneficial. Rally in the Valley. So Rally in the Valley is not taking place this year. However, it has been a hugely popular event in the past, and it is community-wide. It is an all-day celebration of folks in recovery and how they got to recovery. We would like to, bring it back next year. We would like to make it even larger than it is or was, because it has proven to be very, very successful, and everyone who attends that event has nothing negative to say. They've networked, they've met with folks in recovery, they've developed a support system. So we would like to see that continue, even though it's on hiatus for this year. Danny's Ride. Danny's Ride is a contract that we currently have where we have identified one of clients' needs, huge needs in this area is transportation. Transportation getting to treatment, transportation getting to outpatient, transportation getting to meetings. So we contract with a company called Danny's Ride. And essentially what it is Nancy, the founder of Danny's Ride, initiates and schedules different Uber drivers to get our clients to and from treatment when they are in need. We would love to increase the contract because we know that our clients have difficulty in this area. And even though we do offer them some bus passes and some other forms of transportation, there are remote areas of this county, such as the Slate Belt, where bus passes just don't cut it. People can't get there. So we would like to see that program increase and thrive, because that is generally one of the biggest barriers to treatment is people can't get there. Job training at the Fab Lab at the Fowler Center is actually something I just learned a lot about. So the Fab Lab is a program at the Fowler Center where folks can come in, they need to have a membership, but you have access to state-of-the-art equipment and job training from certified instructors, and they can teach you woodworking, metalworking, electronic programming, molding and casting, and recording studio stuff. So you can work with instructors one-on-one to get job skills. Then you can practice what you've learned there so that you can go out in the community and get a job in one of these fields. I had no idea until one of our recovery centers directors brought it up to me, that said, if we could provide folks with memberships to this center so they could get on hands-on job training, that would be huge, because that is one of the barriers as well, folks coming out of treatment and their job skills. Generally, they don't have a whole lot of job skills. So this would give them the opportunity to enhance their skills and get a good paying job. Purchasing of AA and NA books. So generally traditional AA and NA meetings use the big book or other AA books. So we generally provide those to our recovery centers, but there's always a need, and not everything is available online. So they have told me that this is a huge need, and we would like to provide it for them. Scholarships for expenses at sober living or those new to sober living. So this is giving those folks who have lost their job because they are in treatment. They're coming out, they may not have a place to live, or they may not have any way to get food or rent or anything. This is giving them scholarships and assisting them until they can get a job or a stable place to live or back on their feet after going to treatment. A lot of clients we talk to will not go to treatment because they don't want to lose their job. If I go to treatment for 28 days or 15 days, I'm going to lose my job. And then if I lose my job, I lose my house. And if I lose my house, my kids go into care. It's a whole string of events. So that is what we were looking for with the scholarshiping and marketing materials. So we have in the past done a lot of billboards and things of that nature. You'll see on 22, or at least you did see on 22 for the longest time, the 829 help number billboard. We would like to continue with that. We would like to do some other marketing regarding fentanyl and opioid specific. I'm working with one of our prevention providers to do a social media campaign that focuses on Instagram and TikTok and YouTube and all the places that the younger generations tend to focus on, so that we can really hit them, because I don't have any way to track how many people see the billboard on 22. I'm hoping it's a lot. I mean, we're getting a lot of phone calls at the 829 help number, but that's our rough plan at this point.
All right, thank you for the presentation, Kathy. So I'll see if there's any questions anyone has. But I don't know. Ms. Vargo Hefner.
First of all, it makes me sick to hear you go, the younger generation, I'm looking at you, and I feel like a friggin' dinosaur, but thank you for your presentation. It makes me sick when somebody says, and I go, oh, I'm old. I think it's huge, and I think it's very comprehensive. There's something, we don't have to approve this, right? This is just, you're being transparent and sharing it with us. I think it's great. Some things I don't think are so great. So I'm just going to throw them out there and you could rethink them. I never see enough money in actual treatment. Like I see you're doing a lot of early intervention, prevention. I realize with fentanyl, and it's, you know, it's lethality that you really have to educate. I get that. But I think trying to do like prevention at a college is too late. Like, I agree you should have more treatment at a college level. I mean, and maybe a certified recovery specialist is the way to go, but putting like, making sure that the college counseling centers are really equipped with a SAC or a substance abuse person, I think would be a better use of the money. Because there might be a college counselor, but they might not really be a drug and alcohol counselor, especially because some of our schools around here are smaller. When you say intervention services, are you talking about the classic traditional definition of an intervention, or are you talking about treatment? Because the intervention that I think of in substance abuse is we all come in a room and I say, Kathy, you know, there's a problem and their mother's there, and that kind of intervention provider, or are you talking about just getting people to services?
So both. So getting people to services, I mean, there's not enough case managers, there's not enough qualified case managers, and what we've also identified is that not all of our case managers know all of the resources and everything that is available in our county or others. But there has been a lot brought to me as far as creating something like an intervention service where you have a company who provides intervention services. They've identified someone in need, everybody comes together, they get, you know, it's a lot like what I would equate to like a family group meeting in children and youth, you know, where you get the providers, you get the individuals, you get the family, and you kind of pull everybody together, and it's an intervention.
So, but it sounds like what you're saying is more like an intervention light. It's like, because
Yes.
the old school was, here's your suitcase, you go where else. So you're just saying, let's get together and talk about it, what are our options? Okay. Okay. And then I think this Danny's right. I think it's unfortunate that we only get to see your office once a year. So if you could give us some lists of some of the people that you're still contracting with and what's going on, that would be helpful. Because, you know, COVID notwithstanding, we missed a lot of this stuff over the past few years. I'm not interested. I don't think it's a great use of money to send people to Founder's Day. I think that AA and NA are separate entities, and they should remain as such, and people in AA and NA would tell you that. But I think if there's training programs, or I think if there's other things, or if people requested a scholarship or a subsidy to go, that might be different, but, you know, that's just my opinion. I think this training lab is great. I don't think enough people know about that. So I guess you're using the recovery centers to talk about those things?
Yes.
And what else did I have a question about? You said the thing was on campus, and so you're talking about under adolescent recovery services, you're talking about the APGs with the REACH program, the adolescent peer groups that they have?
Correct.
And trying to create those, because we have been talking about those for many, 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 many years. So I think it's great if we identified a place. You know, I think it's great, and I know that there's mixed feelings. I think people say, hey, let's give lots of money to activities because addicts need stuff to do, but the other side of it is, how are we tracking relapse, and how are we tracking, like, a lot of people will use these, how do you make sure that some of these scholarships you are giving are not revolving doors for the same people as opposed to folks that are really kind of stepping up and really trying? So I assume you have some vision about how to monitor that?
So that is the one piece of this settlement money that we're not sure of, actually. So when an SCA requests money or a county requests money, it goes to the trustees, and then the trustees basically hand the county the money. So we have not been told yet what the reporting requirements on this money is, because let's face it, no amount of money comes without a string attached to it. So we haven't been told what that looks like. I mean, DDAP does that a lot with us. They'll hand us money, and then later they'll tell us what the reporting requirements are. So I'm sure there is a way that we're gonna have to track and identify how we're using these funds and for what population and, you know, all of that. It's just that has not been identified yet.
Okay, yeah, I understand that. You're not linking any of this money to the existing drug court or the people that are graduates of drug court?
I'm not anything specific yet.
Okay. And they're not getting a piece of this money. This is all just coming
This is
from the
all
settlement to you. That doesn't come through the judicial system at all.
correct.
I mean, the only other thing is I didn't hear, and you mentioned in the beginning who it could be used for, and you talked about first responders. So I don't see any kind of first responder intervention in here, or trauma and addiction stuff, so that might be an interesting direction. But again, I think it's really comprehensive. It looks like you've done a lot of hard work. You know, I'm just a picky old drug and alcohol counselor from a long time ago. So, you know, after so many decades, you just hear the same things. But I you know, people are still dying from this. So I think, you know, thank you for what you're trying to do.
I just wanted to comment on the treatment piece of it, because we talk about this a lot, and it's sort of fascinating to me that we have enough treatment money for the folks that we serve. So we have not, at least since I've been here, run out of treatment money. And when we are running low on treatment money, we've been very fortunate that DDAP has given us additional funding. So the reason we focus so much on the prevention and then sort of recovery is because the current block grant dollars really do fund adequately the treatment needs that come across our way. So we don't turn folks down for treatment services because we don't have any funding left. So I just wanted to make that point, just so that you know that those needs are being met as well.
And I'm not saying that you're not. I
Sure.
guess there's just, to me, what I hear here, and then what I hear in my own profession, and then when I go out in the world, and the people like, I can't get into treatment. There's nowhere to go. There's no detail. So there is a sort of disconnect between the people that are really out there looking for the services and those, we got the money, we'll send you. So
Sure.
how do we, if there's a way to use this money to bridge that gap, it would be fabulous.
I think the number one item on that list is probably the biggest, newest way that we would do that with the mobile outreach. Because we have the recovery centers, as you all know, throughout the whole county, and Kathy mentioned. And they're pretty well advertised, they're very well used. But we know there's pockets, you know, within Bethlehem, within East End, within the Slate Belt, that we're not getting folks from that we know would benefit from the services. And so, to your point, we would be able to hopefully serve a whole lot more folks in the county in that capacity with a mobile outreach.
Is there a
team.
dedicated hotline or a way, like through IRIS? Because, you know, you call IRIS for
Sure.
crisis, but do they track drug and alcohol calls or somebody calling like a family member who needs help? Or
I'm pretty sure that they do. I'd have to double check with Gary. But the 829 help, so we initiated that about 2-3 years ago. And so those calls go to drug and alcohol during the day, and then they get call forwarded to the IRIS folks after hours. So those are easily tracked, but I'm pretty sure that Gary has his Excel spreadsheets of, because we have to allocate the funding back, right? So, not the funding, the expenses. So however many aging calls are taken, those get charged back. That time gets charged back to aging, and the same thing for drug and alcohol. So, thank you.
Thank you.
Mr. Kusick.
Thank you. Good presentation. This is a department that's traditionally been underfunded for years, so the availability of this money is certainly well put to use. My question has to deal with the availability of fentanyl test strips. Is that something that would be provided for in the settlement?
So actually, currently, we are waiting for the state to pass legislation regarding harm reduction such as needle exchanges, fentanyl testing, and those kinds of things. At this juncture, only Pittsburgh and Philadelphia counties are allowed to and able to proceed with those methods of harm reduction. So that would be something that would be explored. I can't say at this time because right now it is still not legal.
Okay. And then the other question, and I think it should be, the other piece is $500,000 for a van. You weren't here last week, but
Can't do this again.
this is the third very expensive van that we've been asked to fund. Could you maybe tell us why you estimate the cost of the van is $500,000?
Sure she can.
I did talk to Kathy beforehand. I said, we're gonna talk about this. So it's a ballpark. Kathy went to check this program out in New Jersey, and in the meantime, I told her I would do some little Google searching, and honestly, it was purely for the type of van that I hadn't envisioned when Kathy told me about it. So it certainly could be, potentially less. It's not a treatment mobile van that, has got the medical equipment and all that stuff. So theoretically, yes. Although, is that just for the van or also the staffing of it? That's just the van. So just a ballpark, Mr. Cusick. Perhaps a high one. And I think, I'm not thinking necessarily like the 15-passenger van. I think we're thinking, but not that big either. Somewhere between, so.
Somewhere between a passenger van and a Winnebago.
Yes. That's about the best I could tell you. So, you know what I had, sort of like the Lanta vans, right? The folks that.
Metro Rider.
The fixed, yeah, like the Graysdale van. Doesn't have to be, we just sort of need to see what the needs are. The folks in New Jersey have that kind of van, which is why I searched for that. But certainly if our needs can be met with something smaller, that would be completely fine. You're welcome.
All right. Any other questions?
Yes. Sorry.
Go ahead, Mr. Gafredo.
I agree with Ms. Hefner that college would probably be too late to be educating somebody, but I do think education and prevention is probably the most effective way of reducing the amount of people in our area that are actually taking these drugs, because once you get addicted to something like heroin, it's very hard, and as a firefighter, it seems like we would get almost more calls anymore for overdoses, and it seems like we'd get the same people until eventually they die, which is terribly sad, but as a father, I want to hammer into my kid's head how dangerous and how not all drugs are alike, and heroin is not, there's things out there that Percocet or Vicodin after a wisdom tooth operation, they don't correlate those things. They don't understand how that is a low dose form of heroin. It seems like the education is lacking. Maybe it isn't. I've been out of school for a little while, but what are you guys doing? How are you seeing success in getting it into the kids' heads early? And then are they still prescribing stuff like Vicodin after a wisdom tooth, or is that happening all the time still? Because it seems like that's the root cause of the problem, and that's why there was a settlement. But it just seems like we're doing the same thing and expecting different results. And then to piggyback on that, is there any correlation with the fire departments in the EMS when there is an overdose? Do you know who those people are? Are you guys reaching out to those people right away? And then how do you track whether they relapse and if they, do it again? Because I feel like if we don't have the data on it, how do we know if we're succeeding?
So
I know I threw a lot at you there, I'm sorry.
Okay, so I'm going to do my best to answer answer the questions in order, but you may have to refresh my memory. So just the first responder questions, I know that the Bethlehem Health Bureau is tracking when EMS or police or fire do administer Narcan or they're called to an overdose. So we're working with them on basically compiling stats and making sure everybody is reporting this information to them, and then identifying those pockets of where the need is, right? Obviously, the need is everywhere, but, are certain precincts or certain areas seeing it more than others? As far as our schools, our prevention providers in our schools, we do have two currently, Center for Humanistic Change and Valley Youth House. They are both doing variations of current drug trends and a HOPE program, which is heroin and opioid, and they do touch on that stuff, as well as the Caron Foundation program with educating students and student athletes of, just that, taking Vicodin for, a pulled tooth or a wisdom tooth, that can lead to other more harmful drugs. So we are working, it's just, we're working with our provider to do the best job they can do with the limited amount of staff. We have had some resistance with our schools. We're better now than we were a year ago or 2 years ago because of COVID. They are allowing providers into the schools. We are providing that programming, and we're trying to reach as many kids as possible. And we're trying to reach them earlier. So even though I did bring up the college and the high school stuff, we are trying to reach middle schoolers. We're trying to reach the 5th and 6th grade students that ordinarily you wouldn't think that they need drug and alcohol awareness or drug and alcohol treatment until a 10-year-old calls my office and needs to get into treatment or needs an assessment.
Right. And one last question. Is there any way that the 911 center can be teamed up somehow with drug and alcohol as far as if there's a basic life support call or, comes in as a drug overdose? Is there any way then you can track that and that case and see if there's any, follow-up with that victim or patient? Considering that's a county-run organization.
What's a question I certainly,
So
we
she
certainly
talked
can
about
look
how
into.
they track it with the
Yep.
Bethlehem Health Bureau. Well, our 911 center is obviously, we see every single call that comes in. Is there any way that we can earmark when we see that's a drug overdose?
Sure, understood. I'm not sure of the answer right off the top of my head, but we can get back to you on that.
I just think data is the most important thing. I feel like we don't know how big the problem is. We know we have a problem, we just don't know how big it is and then if we're succeeding or not. It doesn't look like, and I'm not saying the countywide, just in general, we are not
problem.
doing well with drugs in this country.
And with the warm handoff program that Drug and Alcohol has with the local hospitals, so those folks who are getting picked up and taken to the hospital, we have a warm handoff program where we get those folks hopefully connected right to treatment if they're willing. So there's some of that goes on. I just have to find out more specifically about what you asked.
Thank you.
Sure.
Any other questions from any members of council? If not, I'm just going to thank you. That was a great presentation.
Thank you.
I was thrown back in my seat a little bit when I heard that we have more than enough money for treatment. It tells me how things change over time, because that's always been the battle, especially in human services, preventative versus, as of now, treatment, and different regimes have tried to attack it different ways, and usually drug and alcohol aging, and they weren't as, let's just say, as wealthy with resources as some of the bigger, mental health in general, or children and youth certainly. I was concerned about the treatment, but you addressed that, so I'm glad that we have more than enough treatment. I agree that I have no problem with the plan. I think it's great. You finally have some extra resources to use, and I think getting out into the community is a good thing. I'm glad you're getting into the schools, and with all due respect to schools, I saw a film the other night. They were discussing things on one of the channels, C-SPAN or something, that I drive my wife out of the room with when I put on sometimes. But anyway, they were having a lecture and they showed educational films from the 50s and 60s that were shown to kids. And I'm thinking, oh my God, a lot of those people are running these agencies now. And the guy sitting on the edge of the desk in his suit and tie saying, children, you should know. I'm thinking that won't work in today's world. So while I normally would not be happy to help the schools out, because Lord knows they raise taxes every year and they seem to have a lot of money, or should have. I think it's good if we can supplement and get the word, especially to the younger kids. I mean, I think that in today's world and what they're seeing and what they're dealing with, elementary school isn't too soon for children to be aware, like a soft approach. And I don't think it's controversial. I know some topics parents are going wild about in the schools. I don't think the school districts will get any blowback from an education program as to the harm and the potential harm to themselves or parents with drug use. And as far as the other things go, I did notice the van, but I realize I no longer understand values on vans, so I'll have to do my own research. But yeah, I think, everything's fine. I wish you a lot of luck. It's a terrible scourge, and no one has the exact answer. I did want to ask about, since so much of this is reaching out, marketing, what about something like Narcan? Are we doing anything about that, or is that mainly local municipalities are dealing with that with their emergency crews?
So generally, our Narcan is distributed by the Bethlehem Health Bureau. If anybody wants Narcan, they can just reach out to the Bethlehem Health Bureau and they will distribute it. We have it available in all of our recovery centers. And a lot of our providers and provider staff have been trained on the use of Narcan. So have all of our drug and alcohol staff at the SCA. So we don't distribute it per se, but we have entities that just do our distribution. But with this mobile van, we would also be able to do the training and Narcan distribution, which will get it out there a little more readily than someone actually having to go to the health bureau. It would be readily available.
I guess I'm hoping, as you mentioned, some of the more outlying areas, and I don't know, that some of these some of the volunteer services that are out there, the ambulance, fire, rescue, that they have these. I would hope they would. I mean, I know they're available upon request. I think that's almost now, to me, is important piece of equipment as some of the standard life-saving equipment that are in those vehicles when they go out. And then after the fact, in terms of treatment, and as was pointed out, repetition, that maybe the appropriate agency is contacted. But I think, I'm glad you have the funds to move forward. And I would guess this is your plan, but going forward, you're going to be looking at what's working, what isn't, and you may decide to shift things.
Correct. So this plan was just, like a wish list of everything we could think of right now. So this is $11 million over 18 years. So if we're 3, 4, 5, 10 years down the road, our priorities may shift and we may identify a different need and we may need to change course. And everybody understands that.
Well, over the 18 years, if Ms. Vargo Hefner has questions, I'm sure she'll address them to you. But anyway, are there any other questions? All right, thank you. Thank you, Ken.
Thank you.
Next, we have an update on Graysdale.
Thanks, Kat. Just one more visual for the van, and I know, and I should have just let it go, but just so
You're
that this.
overselling the van.
It's not for that. Part of the purpose is to be able to do, when we do the mobile outreach, to do assessments and intakes on clients right away. So just in terms of a visual, it's why we need a little more than a passenger van and not a Winnebago. So that's all.
Good evening. So Sue's handing out some of the information for this evening, but I wanted to go over this. This is, I think, the second page. This is our new marketing plan, and it goes.
Before you start,
Sure.
I know that here she's hanging out. Is tonight meeting, the meeting where we discussed the plan, the money that was appropriated for Graysdale, and there was a component to it about the physical structure. Was that going to be
Yep,
discussed tonight?
that's
Okay,
absolutely.
Thank you. I just was watching my time. I just want to make sure you have.
We'll go quickly over
No
a couple of
problem.
things.
No problem.
So you could take a look at this. It's earn a sign-off bonus, get paid for life. It's to revamp what we consider a pension, because the younger generation really doesn't understand what a pension is. So they know what sign-on bonuses are, so we're talking sign-off bonuses, which is the pension.
Oh, they're still not going to understand.
Well, they do want to retire early.
Didn't we all? I mean, I would say, you know what, it's good though, because I have a view of these benefits.
Right.
But I refer to Mr. Goffredo, who's my young person mentor, and we have discussions. He and I have had discussions on what the younger people who are getting jobs, what they believe in, what they don't believe in, what they want. So, I agree. I think that the pension, I know, even I talk to younger people, they don't even believe Social Security is really going to exist. And so a pension, they don't trust anything or anybody. So can't say I don't blame them at times, but, I'm sorry. Go ahead.
So I just wanted to show you that. So you'll be seeing billboards and ads with regarding that. And we show a lot of interest in some of our partners in our marketing. So we're hoping that will come to something.
Can I just ask a question?
Oh, okay.
Did you, like, A/B test this, like, with, like, a focus group?
We didn't use a focus group. We talked to our marketing people, and we talked to La Mega was one of our things, and they thought this was a great idea to focus in on the pension.
But in this way, with this
Yeah.
messaging? Really?
Sign off bonus for life. Exactly.
I think we talked about this.
You mentioned it, you were going to burst my bubble the one day.
I'm sorry, I did talk to her about this a while back. I thought, is there some way we can address this that somebody would like, oh.
I'm just saying, in my mind, sign off sounds very terminal.
Oh,
And I'm like.
for nursing. yeah.
Wow, you might as well have just said check out. And that.
Well,
to
it
me,
wasn't,
like,
we didn't want to use the term sign on because
I
it's
do
not-
understand.
Yeah.
Maybe if you said sign on bonus.
We like the get paid for life. It's almost like winning the lottery when you do your scratch
I
offs.
do like the get paid for life part, because that's very positive, because it's like, get paid for life, not like, sign off, it sounds like you're like, I don't know, I'm just saying, in my own mind, which
Okay.
might be dark, I don't know,
All right,
that's what I'm saying.
it's your mind. I mean, whatever's in there is yours.
So then we'll,
I guarantee you do not want to be in my head.
I'm sorry.
sure.
I know you want to get started. Mr. Lott, you kind of want to let
Just
her
real
get
quick,
started.
get paid for life is great. I mean, in my last life, I can tell you there's 700 members in the Lehigh Valley that 250 are on retirement. And when they go to the meetings and talk to the young members do get it. I mean, it is hard to go to, I did this, I went to the different vote techs and explained, I realized pension was not a selling point to the young kids. But when after you're in the workforce, and I think that's who you're marketing a little bit, you start to realize that security out in life. So though I do agree with Mr. Heckman, it's not that great sales point it once was, but if people get educated on, and if they don't trust Social Security, that's even more the reason to want annuities or pensions, 401ks and so forth. So I think it's just getting the word out and getting these people, and maybe some of your own, I know some of the ads talk about that, but maybe you can have a retired person saying, hey, I'm living here. And but I'm just saying, that works with my members. When they see the guys like me come back and say, I was in Belize last week and I'm 58 years old and I'm traveling because of a pension.
Right.
Because of a pension.
Right.
You know, I mean, if they understand what that word means, you know, it's a wonderful thing, so.
And part of the marketing.
Just thought I'd add my 2 cents.
Part of the marketing is to divide it up in different job classifications and show how much like an average person would make. So we break it down to show you what happens in 20 years or what happens with less time, but older.
Go ahead.
But, I mean, I think that, I mean, I understand it's not a great marketing, I lived that a little bit myself, but it's something so special we have with our county home. I don't think we can ever ignore that. I think it's a great, compared to all the other homes out there, this is what we have that they don't have. So to leave it out of marketing, I think would be a huge mistake. To figure out how to market it properly would be a huge benefit. Thank you, that's all. I'll let you get on.
Thank you.
No, that's, I mean, I think it's the old marketing tool, it's a hook.
Right.
And hopefully, you know, we live in, what, a 15-second world now? If you don't make your point in
Yeah.
15 seconds, people move on.
It starts the conversation.
Yeah, it starts a conversation, and I agree. Then you can get deeper, as like Mr. Lott said. Did you want to add something?
But I like that word security. So if it was security bonus, I'd be like, oh, a security bonus. That sounds secure. That sounds like something I can depend on, you know? Like, still sign off sounds like turn off, like terminal, like it's nursing home. It's like tough.
I think she's noted your objection.
She has noted. I'm like, oh, man. I'm not an advertising exec.
Right.
I'm just telling you, I know what a pension is. I'd love a pension. That doesn't scream pension to me, so.
Okay.
I'm like in the middle of the youth and the elders, I think. So
I'm not
like,
going to say anything on that. Okay, obviously you
Keeping
touched
it
a
light.
nerve, but I'm going to
sorry,
let
I'm
her,
drinking coffee now.
I'm going to let her,
So
Continue. Go ahead.
We'll quickly go over June's
Yes,
report.
please.
So our census was 399 on average. We have 289 open beds. Referrals were 325. We admitted 5 people. Our wait list is still 50 plus. We had 7 discharges. Our average PPD for June was 2.84. And then I'll get into the next topics that we're going to talk about is we had our annual survey, and then the CMS guidance update came out. So that will tie into Mike's presentation.
well, and on this sheet, the data sheet, is there any, the June report, any questions on this? Before she gets into her, because she's going to do a full, go ahead. Go ahead.
Any staff hirings or progress made on that front?
We've hired, we continue to hire. We still have agencies coming in, but we do have hires coming through. One of the agencies just told us that they have about 40 CNAs to come on board. 17 are guaranteed for us so far.
Great.
So,
Mr. Kusin, are you done? Finished? Mr. Kusin.
Yeah, on the report, I would note you're looking at the number of empty beds here, 289. Now, council did pass that resolution to create the daycare, and that will eliminate a certain number of beds. I guess my question is there a plan to sell those and, account for the fact that those beds will no longer be in use?
so there are 27 beds that were on that short-term rehab unit. We could, if needed, move them into some of the very large private rooms and make them semi-privates. They're already set up to be semi-privates, we just use them as private rooms. So if we wanted to ever get back to 688, just putting it out there, those 27 beds could go back in. We could,
Can I ask a question?
Oh, I'm sorry.
What is, I know that beds are kind of like a commodity. So like a stock, if you trade it when the beds are worth something, when they're not worth something, what is a bed worth these days?
I could get that number for you. Right now, because there is closings, a lot of closings, there's a lot of beds out.
Yeah, so they're really not worth that much. So what we should do is hold on to them until they're worth something, right? Because otherwise, we're just giving them away.
For years, we carried our other beds for a very long time. When we were 725 and then we went down to 688, we carried those beds, just on paper.
Right.
And then we
it does
sold
nothing
them.
to carry them on paper. But it would do something to sell them off and then not have them if you needed them, and to sell them for like nothing.
Correct.
Right? That's what I thought. Okay.
And on that, though, they're not factored in, your totals, beds aren't factored in at all on your,
They are. You carry them on your bed list, so it counts as part of your, for certain financial marking. But if you could raise the number, 27 beds is usually what we've always had open. It's actually been more than that, but.
yeah, I mean, and going forward, I mean, I hope, how long has it been now? When we passed the plan, was it a month now? I mean, I know you just started, so we'll see how that works out. But I don't know as far as, carrying, I know I've had this conversation with the executive a few times, and I guess at some point, we're going to have to think about if we don't see an increase, because you're getting a lot of referrals. And I know in my discussions with Mr. Cologne, I don't think referrals are a problem now. I mean, it's staffing. And that reality is going to be, where are we going to be with staffing? And I think at some point, well, I'm sure you're already doing it, but we're going to have to, is there a level of where we feel comfortable? Let's say we're going to work towards this number. I mean, I think right now, I'm sure we're saying, hey, we want to work to, what is it, 690 or something like that is our total capacity?
688 is our
688.
capacity. And then CMS just put out their guidelines, which we've been talking about forever now. So I'll go over that
Okay.
next, what they're
Okay,
saying.
good. Yeah, and I mean, I guess my point is, that's a great goal. How attainable that would be, especially in the near future.
Correct.
I think is questionable. So what is reasonable to go for, and see where we're at that point, because it's all going to depend on staff at some point. But I'm sorry, go right ahead. Your report.
So before I begin reviewing the Department of Health survey, I would like to thank the staff at Graysdale for their commitment and dedication to the residents and each other. It was reflected in our survey. I think it was a very good survey. So I am so proud to lead this team of group of individuals that come together to form a united front to give their best and their all for all the residents at Graysdale. So Department of Health was in on June 7th. There were 6 surveyors, and they do what they do. They come in, we do the intake, and then they hit the floors, the kitchen, they go everywhere to review everything. So what they came up with was 4 F tags, and the F tag means the federal tags. So one of them was failing to follow up on an injury of an alert and oriented resident. We investigated it. We talked to the resident. The resident expressed and told us what he thought occurred, or he didn't remember what occurred, and we had left it at that. Department of Health said you should have gone back and maybe asked more and more people. He was alert and oriented. He scores very well. So unfortunately, it stopped at him. We had a accidental hazard. There was a lack of supervision on someone who was a fall risk. We had a doctor order not followed. So we have someone with dementia who was ordered to wear a brace. This person does not want to wear a brace, and it was recorded instead of refused. It was not applicable was marked. So Department of Health said you should have put refused, you put not applicable. So we got dinged on that. A bed rail consent and assessment. So we had a resident who was out at the hospital and came back, but unfortunately, when they came back, they were put in as a new admit and not as just a return. So when they looked at the consent should have been redone if it's on a new admit. So we tried explaining that, no, this person was here before and had just been mismarked, but it was an error, so we had to own it. So those were the 4 tags that we got. And we did get hit on a state tag, and that was because since the last survey, we were below 2.7 hours per care per day. So we have since come up greatly in our numbers, so, and they understood that, and they know that we have done and did everything possible to increase those numbers. And I talk to them weekly, and they are satisfied what we do, and they know that we're gaining ground, so. So we have submitted a plan of correction, and the plan of correction should be done by 7/16, and then they'll come out for a revisit, and we'll see what happens.
Ms. Vargo Hefner.
Do you want, no, go ahead, say what you want.
No, I was going to ask a
So
question.
these are less than in the past, correct? Significantly less?
Yes.
And two sound like they're verbiage. Is that, am I hearing you correctly?
Correct.
So the injury follow-up and the accident had, like, I understand that. Do you have to write correction plans for those two?
Yes.
Okay. And then this-
Education is basically what the main plan of correction is.
And then more on the injury follow-up, is that more staffing?
Right, so these other staff should have been interviewed instead of just talking to the alert and oriented resident. So they should have asked staff, and
So that's a staffing, it's not these are not person grievous harm except potentially the accidental hazard?
Correct.
Am I correct on that?
correct, so they all fall under the scope and severity of a D. So that means that there's no actual harm with potential for minimal harm.
And, the only reason I'm asking that and I'm highlighting that is I understand surveys and you do, but I don't think like everybody does. And
Right.
so they hear, there's 4 errors, oh my God, life and limb, and it's paperwork. So I think people need to hear that. But I do have a question about that, is didn't we hire some dedicated staff to be able to review these things so we would not have the dings? Were the RCN supposed to be part of this, or what, didn't we? a year ago-
And we do. So we had a mock survey in which we did really well on. Not that you don't want a perfect survey, but when you get a perfect survey, the feds also look at you. And that means there's a federal survey that comes in. So that's why I say, while this is a lot of paperwork, I'm very happy with this because I don't want the feds in the building.
Okay. And as far as the state tag, have they, when you're doing a survey, they dialogue with you. Did they have any thoughts or conversation about those numbers? And have they heard you, or that just has to go on paper and it's like?
It just has to go on paper because they understand, and that's when they said to us, there is nothing you haven't done. I mean, I give them a report weekly. I even report now weekly when I don't have to because we've been over the 2.7, but I just want to make sure that the area, Lehigh branch knows that we're there. We're not going to give up, though. We still have everything in place just in case.
And how did the staff react to this? Is staff happy? I mean,
You wanna
'cause
tell
I know
them?
that when I go through a survey, I'm happy if my boss doesn't find anything. So I just wonder how the staff react.
Well, I think maybe part of what Jen wants me to share is the surveyors this time, because I go to the exit interviews, said what a marked change there was in staff morale and attitude this year compared to prior years. And I really, I don't have it with me, but I was like writing it down verbatim to really, to keep that. And so they were very complimentary of staff. And I think, Jen and her team have worked for 4 years now, 3 years now, to really try to turn the ship and shift the culture. And it was really, really rewarding to finally hear outside folks who license us, no less, be complimentary of the morale at Graysdale. So we were really proud of those efforts. Thanks, Jen.
Any other questions or comments? I think it is important that you pointed out, it's almost like a speed trap. I think some of these guys, they don't feel they're doing their job if they don't find something, and then like I know they found a mop on a stairwell or something, and they'll write you up. And so, as a public agency, it's out there, we talk about it, but it's really, this actually is a very good report as far as I'm concerned at this point. Okay.
So here we go. We finally, on June 29th, CMS released their guidance that we have been waiting for with regards to how they want the beds to be at a nursing home. So there's several areas that they tackle in this report that I gave you. The area that I'd like to focus on, obviously, today is the resident rooms. CMS has made recommendations, and only recommendations, to the 1- and 2-bedded rooms. And so this is not a mandate or a regulation. They are not saying we have to get rid of the 4-bedded rooms or 3-bedded rooms. So because we are prudent planners, we continue to work up possible scenarios with regards to the rooms. We must make every effort, though, to have as many beds open as possible to ensure that if there is any person with Alzheimer's or dementia who live in Northampton County and are on Medicaid, that Graysdale is a home to them, and we will find us in their time of need. So I know we talk about reduction and everything, but there's 50-plus people waiting. There's 300 people in the hospital that could use us any given month. And I just think that we need to keep that in mind as we talk about this.
Can I ask you a question?
Sure.
Because I just want to be sure, since I'm looking at it, I'm reading. It sounds actually, I forget marketing for a second, but from the standpoint of what we have to do, they're saying beds certified after November 28th, 2016 are going to be required. But it sounds like they're just advising, they're allowed, 4-bed capacity is allowed. And I'm not saying that it's preferable and people aren't going to look at that.
Right.
But it is allowed, and then they went, the White, or sort of talked about the briefing in that, I mean, they obviously are looking at saying, hey, you know, we'd like to see, you know, they're giving you advice on private, singles occupancy as well, but it seems it's more advice-driven than.
Correct.
Okay, thank you. I just was reading that real quick, doing a little speed reading, and I wanted to get a sense of that. All right, go continue, unless anybody else has a quick question. Go ahead, I'm sorry.
All right, so no, on that, again, as being prudent planners, Mike has still worked up all, some scenarios for us with regards to the 2-bedded rooms, if we wanted to go there, or 1-bedded rooms. So I let him come up.
Yes, please. Thank you. Oh, wait, hold it, we have a question.
Well, he's on his way. Can
Yes.
He's on his way.
I think it's interesting you have the inaccurate diagnosis or assessment and addresses the psychotropic meds. So is that helpful to us or a detriment to us? I mean,
It's helpful. We've been revamping our whole psychotropic medication layout and what we do. So we are currently working on that. Quality measures has been something that we've been working on just before COVID, in the middle of COVID, and we continue to pick up steam with it because that's one of our quality measures.
And that was one of the problems for the longest time. So it's interesting to see that they're at least letting us revisit that and maybe potentially re-diagnose some of those folks
Yes.
or those meds.
And
So
which
that's-
we started working with the doctors on this, and maybe taking out those that really have like the schizophrenic diagnoses that don't really count into the psychotropic medications.
Thank you.
You're welcome.
And just if I can, I apologize, Michael, but that's a good point. Since our population is sometimes a very special need population, and I think it's going to continue to do that more and more, without looking at the report, if you could just say, the idea of some of the challenges we face, you don't feel there was anything in the report that would be overly onerous for us to being able to handle. Psychotropic drugs, I know also we can't really restrain. I mean, and there's a lot of things that we might face on a more regular basis than some other homes do. But you didn't have anything in the report that worried you at this point?
No, I was happy with what they came out with because it seems to be more guidance, whether it's the PPD, then they didn't give us numbers. They gave us more, they're going to follow the PBJ, which is what we follow now under their 5-star rating.
Thank you.
You're welcome.
Now, we've all been awaiting Michael. He's anxiously want to hear what he has to say.
Okay, well, as Jen alluded to, prior to the recommendations officially coming out from CMS at the end of June, we wanted to have a rough idea in terms of the potential implications, both in terms of cost as well as on the census for the facility. If we did have to reduce the maximum occupancy down from 4 to 2 beds, there was also the potential to have to provide private bathrooms for every single room. So we essentially looked at 3 different scenarios. The first being I'll call it the no construction option, in which all we would be doing in this scenario would just be removing any beds from excess beds from 4 and 3 bedrooms to get it down to 2. So in that scenario, the census would be 404, which is basically it's around a 41% reduction from the current 688. The benefit to that is, as I mentioned, there's essentially zero cost to that. So the second scenario that I looked at was if we were forced to provide private bathrooms, as well as reducing the capacity down to 2 residents per room. So in this, we'd be constructing private bathrooms, or in some cases, depending on the floor plan and the wings, I felt it made more sense to just kind of convert an existing bedroom into a bathroom and split it in half, and it would serve the 2 adjoining rooms. So that scope of work, you would obviously have to run new water, sewer, vent piping throughout all of the wings in the main building. And there's also be work required to reconfigure lighting, HVAC, sprinklers, all that. So in this scenario, it had the largest impact, as you would expect, on the potential census. It went down to a capacity of 377 beds. And the construction cost for that is estimated to be around $4 million.
Michael, may I ask a question?
Sure.
Just so I understand that. When you said private baths, I know many of the public homes, there's 1 bath, 2 residents per room. Were you referring to one resident per bathroom in this, or 2 residents per bathroom?
2 residents per bathroom.
Thank you. And this would be all beds, all floors, a scenario where we'd be doing it in the entire facility.
Except for the tower, because that's already set up to accommodate, the tower already has private bathrooms in every single room.
For 4 people?
For 4, yes.
But the 2, you're talking about the older wing?
Yes.
We're not talking about the tower.
The tower, we would really have to make no changes. It would just be removing beds from the tower, and the bathrooms are already in
You'd have
place.
this huge area, right. I see what you're saying. You could take the beds out. So we didn't think about the idea of splitting, like having 2 beds, a partition, and 2 bathrooms. That wasn't thought about.
I did look into it. There's just not enough room in the 4 beds
problem.
to split it and add essentially another bathroom as well.
Now, you know the requirements and whatnot, so I was just curious. Thank you.
Sure.
Go ahead.
And so the last scenario would be 2 residents per room with shared bathrooms. We'd essentially be using the existing, or retaining and reusing the existing bathrooms that are already in place throughout the facility. So in this scenario, we'd be adding partition walls to divide the 4 and 3 bedrooms into smaller rooms, again with a maximum of 2 residents. And that's anytime that you're adding partition walls directly down the middle in most cases, you're often in conflict with existing windows and radiators. So that's something that needs to get taken into account. Again, you're reconfiguring lighting, sprinklers, HVAC. So once again, the cost of this is around $4 million. It came in, as I mentioned earlier, came in the same as the bathroom, or creating new bathroom scenario, just because we would have to do work in the tower.
And the census would be for this?
664.
Thank you.
So very, very minimal impact.
Okay. So you had 3 scenarios that you worked on?
Yes.
All right. Is there anything else before I open it up to questions that you want to say?
That's all I had.
Okay. All right. Any questions for Mike? Mr. Confredo?
Obviously, the first scenario is attractive because there's no construction cost, but what do you guys see as, if you go down to a 41% reduction, are you able to reduce overhead costs? And I know that's probably not your department because it's not your department, but have you guys thought about that? Have you guys planned that out? Because obviously there'd be a huge revenue reduction if we went down 41%.
Tackle that.
Yes, we've started to look at all the scenarios with numbers and where we might end up over time, and we'll reflect that in the budget next year. luckily, we don't have to do any of these plans because of the guidance that came out from CMS, but we wanted to make sure that we were thoughtful in case, you know, a year from now or 2 years from now, they change their mind. So at this point, we don't have to have any reduction in census, and as we bring in more staff, we will start to increase the admissions.
But it seems like nobody, at least right now, nobody's talking about doing full capacity for the foreseeable future.
In terms of full capacity residents?
Correct.
You're correct in terms of needing to bring on more staffing before we do that, yes. But under the current guidelines, we're able to work back towards that goal as opposed to reducing the beds.
Thank you.
Sure.
Any other, Ms. Margot Hefner?
Is there, you looked at the existing bedrooms and the existing, is there any other space in any of the buildings that could be converted and added without incredible cost?
There's just no space.
Yeah, there's not. The
I like your
space that,
faces before you answer, by the way.
the space that we have is already utilized for the necessary items, so there's no room. Unless you want to build on.
Well, that's, that cost is beyond, that's capital projects money, big money. But it's interesting to hear number 3 auction because it keeps you close to the census. I mean, the money is the money, but it's not awful money. It's, you know, is there a way to start doing some of those conversions? Like not maybe next week, but, you know, planning them out over the years or not?
Well, my one fear, if we, obviously aside from the cost, is if we did go that route and CMS a couple years down the road alters their guidelines and then decides that we would need to provide private bathrooms, then we'd be in a tough situation where we would have to probably undo some of the work that we just did to meet the new regulations.
So you'd rather wait and be safe than sorry?
Yes.
Any other questions? I think the CMS and it's taken the heat off of us at this particular point in time. I think, as I said earlier, I think we're all going to have to look going forward at where we think, if we have the home, where we're going to be census-wise. And it all comes down to staff at this point. I mean, I feel confident we have the people that would use the rooms. And I mean, we can even mix and match if we could start going forward. For example, we could do a few to pick up people who might want a private and we could bill accordingly, or just a 2-room without worrying about going whole hog and into it. So I guess right now, I'm glad actually to hear, thank you for the plans, but I'm glad to hear that pressure isn't there so much. Now it's about staff recruitment because it sounds like we do have a decent amount of people waiting to come in. And I really, I don't know, how many county homes are there left anymore, roughly?
17.
Thank you.
Thank you, Mr. Kusick.
Yes.
Well, see, that's what happens when you're a big deal in CCAP. You can answer those questions just like that. No, I think that I want to see the home, obviously, I've never been shy about that, succeed because it's a need in the community. I think at times it's unfair that we put this requirement on Graysdale that it better pay for itself. And I believe that was probably started around the Stouffer administration. And somehow this became this lore that if it didn't pay for itself, it can't exist. I don't know anything in the county that pays for itself. So I don't want to put that on them, on Graysdale. At one time it paid. I'm glad the council did make a move to put money, keep it at Graysdale. We should have done that a long time ago because they brought in a lot of money. So I think this is a great news at this point from my perspective, but I don't know about anybody else. But I appreciate, thank you, Michael. Any other questions in general? If not, call for adjournment.
Oh.
What, did you have a question?
I did not.
Oh, okay, adjourn.
Make sure to ask Mr. Heckman to see the
Oh, yeah.
photos. No, it's okay, Mr. Heckman, I don't have anything from last night, throwing out the first pitch at the Iron Pigs. It was a perfect strike. It's beautiful.
That's right down the middle. I didn't want to do a Baba Booey.
Perfect.
It was closer than I thought it would be.
Yeah.
It was a lot.
Still,
Oh, no, it was great. I mean,
You did great.
that's right. I was thinking, should I throw a knuckleball? Should I do? Then I thought, don't get crazy.